Hi, everyone. Welcome to our weekly webinar on preventing and managing COVID-19 in the workplace. This is our 35th consecutive session. And I wanted to just mention to all of you who are veterans, happy Veterans Day, and thank you for your service. This is Karen O'Hara. I'm the Director of Marketing and Communications with WorkCare. Welcome if you're a first-time attendee. Those of you who join us every week, you know our routine. The session is being recorded. You'll be on mute during the webinar. Please submit your questions using the Q&A function in Zoom. We'll answer as many questions as we can during the time we have allowed. All other questions, including those we answer, are summarized in writing and posted on our website. And we post the recording on our YouTube channel. In the interest of time, I know Dr. Harris has a lot to cover. I'm going to turn it over to him. But for those of you who aren't acquainted with him, just let me tell you a little bit about him. Dr. Harris is an MD, MBA, MPH. He's board certified in occupational medicine. He's WorkCare's Chief Innovation Officer and our Associate Medical Director for On-Site Clinical Operations. And equally as important, he's our go-to physician for all things related to COVID-19 and our response solutions. Now I'll turn it over to him. Thank you again for joining us.
Excellent. Thank you, Karen. And thanks to everyone who has joined us again today. We are continuing to be excited about providing up-to-date information on how to best deal with COVID-19 in the workplace. And today we're going to focus in on two things in particular. First, the one we told you about last week, COVID fatigue, and trying to figure out what to do with it. And also we're going to talk about the impact of COVID from a hospitalization and ICU utilization. So without further ado, we'll jump into our routine schedule here. First, clinical update. Second, microbiology, pathology review, followed by epidemiology, running our numbers in terms of our macroscopic view of the impact of COVID globally as well as in the US. And then we'll talk about prevention, and then finally some workforce strategies specific to recommendations from WorkCare. So when we want to talk about ICU hospitalizations, we need to look at, in particular, what the numbers are from an impact of COVID in the US is where we're going to focus. And then we'll zoom out a little bit and look at how we compare to other nations. And to get started, we're going to zero in on a state that has been impacted from clinical presentation of COVID and hospitalizations dramatically, and that's Texas. And if we look at one of the major hospitals in Texas, we can see their trend histogram here since April of this year, and moving forward to even today, the rate of hospitalizations due to COVID-19 in this facility, okay? And the Texas medical system here, we can then look to, with this trend here, the overall daily, or excuse me, weekly average, and we see a similar trend, right? Back early in the pandemic here, we see that the number of positive cases mirrored what we saw for hospitalizations, and we see that even today. So what does that mean? That means that we're seeing similar rates of hospitalizations that correspond to the number of cases that are presented in the community, right? So we're not seeing a significant shift in terms of increasing number of hospitalizations, and we're not seeing a decline necessarily observing this data in the number of hospitalizations. But let's look elsewhere, all right? Let's look at Ohio. The data from CDC zeroing in on Ohio and looking at hospitalizations from a weekly standpoint, going back to March all the way up to today, we can see a similar pattern that we saw in Texas, right? But early on, Ohio had a higher rate of hospitalizations than that of Texas. And if we look at then this rate in Ohio, and zoom out to the entire network and look cumulatively, we can see again that Ohio is experiencing and this is per 100,000 in the population, a similar trend as well in terms of hospitalized cases of COVID-19. All right. And so as we really ask the question of, are we getting better? Are we getting worse? This begins to paint that picture that, again, we're seeing the same similar trends of hospitalized individuals that have become infected with COVID-19, not at an increasing or decreasing rate. Again, looking at the cumulative number from a standpoint of CDC total numbers, this is US wide now, right? We're seeing per 100,000 the cumulative increase of hospitalized folks who have become infected with COVID-19. All right, and so we'll continue. And you're seeing the breakdown here in the different age groups. So the top line is the eldest age group, 65 and over. The bottom line, the gray zone there, is the pediatric neonatal and hospitalization rate. And obviously, we know and have known over time that this virus disproportionately affects those higher in age. And so when we want to dig deeper into kind of the drivers of this particular phenomenon we're seeing, where, hey, look, we're keeping the rates about the same in terms of number of hospitalizations, relatively the same as what we saw in the spring and summer, corresponding with increases in the total cases that we're seeing, incidents of what we're seeing. Are we getting better or worse in the ICU, better or worse in terms of care and our approach? And we want to empirically say, in this case, that yes, we are getting better from a clinical standpoint in terms of how we approach COVID, particularly in those most ill in the hospital and in the ICU. And we're going to zoom in on this, right? Because obviously it's a deep impact to those individuals who become infected and are hospitalized. They're on supplemental oxygen oftentimes, and again, beyond that, they may have invasive respiratory support in a ventilator, right? And so we'll look at these numbers here and begin to understand kind of where we're at today compared to where we were early on in the pandemic, and look for any trends in our approach and see if there's benefit here from our novel approaches and interventions. So let's zoom into Illinois. Let's look at the impact from an ICU utilization standpoint in Illinois. Obviously, we know that Illinois has been dramatically impacted by COVID-19, as most of the Midwest has here in the US. And this is a depiction of, in the map as well as the numbers here, the number of utilized beds and the total number of beds from an ICU standpoint throughout Illinois, throughout the state. So well over 3,000, almost 4,000 ICU beds, and 911 as of today are occupied by COVID-19 patients. If we look at then the number of ventilators available, well over 5,000, almost 6,399. All right, are utilized as of today. So that gives you a quick snapshot of where we stand in terms of one of the hardest hit states by COVID in regards to hospitalization, ICU utilization. And if we then take a step back and look at the trend over time of hospital beds in Illinois, ICU bed utilization in Illinois, compared to and contrasted with non-COVID patients, and looking at the total capacity of both hospital beds and ICU beds, we can see that the COVID patients, which is down here depicted in the dark blue, peaked in Illinois back in May, right? And then throughout the summer, we saw those levels diminish as obviously the quarantine was well in place and having its effect in a positive way. And as we look to the fall and to up till now, we see those spikes that we're all familiar with at this point in time. And then we see that also reflected in the ICU bed utilization, right? Spring, summer, and now where we're at with regard to the trend of increasing cases as well as increasing ICU bed utilization. Again, we're seeing the mirroring of COVID patient or COVID cases increase with the number of hospitalized utilization and number of ICU bed utilization as well. So, what are some of the interventions? What's some of the evidence that has demonstrated to the clinical community that we're getting a little bit better at treating ICU patients, hospitalized patients? Evidence such as this, published by New England Journal of Medicine, talking about the utilization of dexamethasone. You've heard about dexamethasone. We talked about it briefly before months ago, but there is now substantial evidence demonstrating it. As in this case, over 2,000 patients received dexamethasone, which is a steroid, right? Systemic steroid. And the utilization of dexamethasone in these cases overall provided benefit, all right? In the group, there was two groups compared to each other with and without dexamethasone in the same situation of having mechanical ventilation. And what we saw was that the dexamethasone group had lower deaths, okay, lower mortality when they are invasively ventilated. All right, 29.3% compared to 41.4%. If we look at the group that received supplemental oxygen without invasive mechanical ventilation, we saw a similar effect, 23.3% in terms of mortality versus 26.2%. We did not see a benefit from dexamethasone in those individuals that did not receive any supplemental respiratory support. All right. And so, what does that mean? And what is that? How is that reflected in our recommendations as we talk about improvements that have happened over time in hospitalized patients? It means that if you are hospitalized with COVID-19, at least here in the US, the recommendation straightforward is you're going to receive dexamethasone, all right? And you're also going to receive you're also going to receive remdesivir, and that is an antiviral that has shown benefit as well in hospitalized patients. We presented that previously in regards to its FDA emergency use authorization some time ago, earlier this fall, right? And what we understand about utilization and recommendations in these cases, it's specifically for patients that are on supplemental oxygen. Again, not seeing any benefit to these particular interventions if you are not requiring supplemental oxygen at the time of hospitalization. All right. Likewise, if obviously you're receiving mechanical ventilation, and in this case, ECMO is a process by which we can put oxygen in the blood without having to utilize your lungs. Yet and still, you're going to get dexamethasone, you're going to get remdesivir, and we're seeing benefit in terms of mortality and actual improvement in outcomes from these interventions. So again, we're getting better, and we see other interventions that have helped us improve our outcomes. Convalescent plasma, we've talked about it briefly before, and this is more of a gray area in terms of clear-cut benefit, right? In the U.S., there's been studies that have shown some benefit. U.S. FDA has authorized convalescent plasma for utilization in hospitalized patients. But then there's some studies out of China, there's some studies in other European countries that kind of have a mixed result in terms of is there an actual benefit. Nonetheless, the benefits that we've seen in the data so far still warrant recommending convalescent plasma to those severely ill individuals in the hospital, which is associated with a better or shortened severity in terms of ICU time. So let's look at epidemiology-wise how we're doing in terms of hospitalizations, right? We're not running the numbers yet in terms of our moving to our section of epidemiology, but we're staying still focused in on hospitalization utilization and looking at now how do we in the US compare to abroad, right? Do we see a dramatic difference in our hospitalized numbers? based upon COVID diagnosed individuals? And can we learn something from any differences we might see? So when we talk about hospitalized patients in the US, we clearly see that US leads all of our neighbors in terms of impact from COVID, total number. Clearly, we have the most cases and clearly we have the most hospitalizations. If we break this down now in terms of weekly rate of hospitalized individuals, we're still up there, right? And we see the oscillations over time. We see the nidus down there during the summertime, correlated to the number of cases. And then we see the numbers spike again towards the fall and where we're at today. Again, seeing that same relationship of number of hospitalized patients, utilization of hospital beds with the number of cases. If we look at now from a per million standpoint, right, a population-based approach to look at how we're performing against our neighbors, we're doing better in that regard, right? So at a per million basis, Belgium is up there, surprisingly, right? We haven't seen Belgium at the top of any of our stats historically here, but Belgium is up there for hospitalized patients per million. France is next, followed by United Kingdom, and that is the most up-to-date data that we have as of right now. If we look at then the ICU utilization, total, again, US is at the top, right? Total cases and total ICU beds that are occupied compared to our neighbors. If we break that down again per million population breakdown here, we're seeing then France top in terms of ICU utilization, Netherlands, then finally the United States. So again, this gives us a general comparison of how we're doing. We're not as bad as it may seem, even though we have the biggest numbers, the deepest impact from a total number standpoint, from a per population based standpoint, per capita. We're faring still bad, but we're not as bad as some of our neighbors, unfortunately. So when we talk about weekly ICU admissions, the numbers still are mixed, right? We're not as bad as France, but again, we're still leading our neighbors in terms of weekly admissions over time. And we're seeing that escalation there in the fall and up till now, corresponding with the number of cases. If we look at weekly ICU admissions, same, again, we drop down here quite a bit compared to our neighbors. And we want to make sure that we continue to look at these numbers to understand, are we doing better? Are we doing worse when it comes to utilization of our healthcare here in the US and learning from our experience with COVID from a clinical standpoint? Obviously, we anticipate continuing to improve, and we want to see it to the extent that we start to see a decrease, a continued decrease in death rate amongst individuals who are admitted to the hospital and to the ICU. So now let's look at macroscopically how we're doing in the US and compared to our neighbors here in terms of impact from COVID-19. Total cases as it stood a couple weeks ago at 8.6 million, an increase last week to 9.2 million here in the US, and finally well over 10 million cases. As you all know, this has been a dramatic week for records of cases in the US on a daily basis. And so we're continuing to see spikes in many states here, particularly hit hard in the Midwest, as we mentioned previously. The cases up to 34.6 on a 7-day rolling average here per 100,000. If we look at deaths, again, we're talking if we're looking at deaths in terms of rate, we're looking at 0.2 deaths per 100,000 over the last 7 days. And that was 2 weeks ago, went up to 0.3 last week, and now we're continuing to be right at 0.3 this week. Jumping to how we're doing with compared to our neighbors in terms of total cases, we know that the total cases here on a daily 7-day average here, we've seen a decline. Obviously good over the last couple weeks comparatively, but then saw the increase recently in the last, and this was last week, and then continuing to see it increase this week in terms of 7-day rolling average. If we break this down now per million, We talked about how France was most impacted. We saw the emergence of their quarantines put in place, followed by United Kingdom putting quarantines in place, and finally, what we saw 2 weeks ago, United States and several states putting quarantines back in place in terms of lockdown. We see that trend continuing previous week, and now this week we see United States has actually overtaken United Kingdom in a population-based number of new cases on a daily average, right? And so we're worsening. It's clear, right? We see the spikes in numbers, and we see a comparative worsening of the U.S. in comparison to at least the United Kingdom, as well as France, who has had a decline now. And one now starts to postulate the more dramatic measures taken in France and Paris in those dense areas of France. Have they had their effect in terms of quarantine? And are we going to see, and in like manner, the U.S. continue to get more restrictive so that we may share in that downward trend as we see in France and the United Kingdom? We'll continue to watch that. From a death standpoint, daily new confirmed deaths on a 7-day rolling average, U.S. Is where we were two weeks ago, where we were last week, and now where we are this week. So obviously, we're seeing that increase along with the rates of incidents that we're seeing across the board here. If we look at then per million, that number we've seen over the last couple weeks, we saw France and the UK above us. We saw an increase in France and the UK, and we can still see that trend here, both in France and the United Kingdom. Again, realizing that the death rate and the death numbers are a 30-day lag of the incidents, right? And so what we're looking for in the next week to 2 weeks is France and UK, as we saw in a couple slides ago, will have a decrease in their death rate and a spike in the United States death rate as we continue to watch these numbers. So if we look at new tests, we want to make sure we're continuing to follow this metric because we got to understand, are we getting better at testing? Are we saturating the market with testing? One would hope so, right? If you recall back to the spring and prognostications of having millions of tests available on a daily basis. So let's see where we're at, right? In the United States, we are over 1 million tests a day on a 7-day rolling average as we were last week. But if we look at today, have we had a tremendous improvement? Slight improvement, not tremendous improvement, but certainly we've seen a decline from that 1.2 million when we peaked over the last several days. So we'll continue to watch the overall trend here, which is an increasing number of total tests. If we break this down now per million, per 1,000, we're still not seeing, we're seeing a gradual increase, but we're not seeing a dramatic increase as we see and have seen in France and the United Kingdom. This was 2 weeks ago. This was last week. With the numbers continuing to escalate in France in terms of per 100,000 people, how many tests they were doing. And we see now this week, those numbers stay approximately the same, Germany increasing quite a bit here. If we then look at our metric of understanding the accuracy to which we're articulating the burden of disease in the US, this is where we were 2 weeks ago. This is the percentage of positive tests for all the tests that we're conducting in the US. We see this continuing to trend up last week and continuing to accelerate in that rate of increase today, right? And again, this metric should be going down if we're articulating the burden of disease more accurately. So we're getting worse in that regard as well, according to this metric. So now let's talk about kind of shifting from looking at the numbers of hospitalizations, ICUs, to something that's going to continue to impact the numbers and the increasing incidence in the US. And that is something called COVID fatigue. If you haven't heard of it, we're going to introduce it here today for you. And we want to frankly say, what is it and is it real, right? And when we talk about COVID fatigue, most people probably initially go to a clinical definition, right? Recovering from COVID after you've been infected. And we know, we talked about how once you've been affected, it can take weeks to recover, right? So we're not talking about, in this case, physical fatigue from an infection of COVID-19. What we mean in reference when we talk about COVID-19 fatigue is more the fatigue that happens as a result of being in this lockdown kind of alternate reality, if you would, of dealing with this pandemic. And there's really, if you look at some of the reports, kind of three emotional stages of COVID-19. I like this particular articulation of it, looking at a survey from Indonesia. And this survey looked at over 6,400 people and their journey through this pandemic from COVID-19 since March. And what we saw is a breakdown here of kind of the stages that people go through. First being disruption, right? Life changes, severe lockdown, from an experience of loss of freedom from the quarantine, and kind of beginning that quarantine living. I like the way they put that. Uncertainty, right? You're starting to get kind of mental fatigue of a prolonged lockdown or a prolonged sense of I can't do much outside. And now you start to see the economic impact on a personal level, right? And how it affects your life and your livelihood. And then finally, an acceptance of the new norm, right? And this is long term. We're not there yet. And we'll talk more about that. But that's the long-term behavioral shifts and looking to kind of a new outlook on life. All right. And so if we keep these stages in context, we want to then kind of layer on top of that another perspective of COVID fatigue and what is it and the reality of it. Right. This particular article speaks to COVID fatigue from the perspective of UC Davis psychologist who talks about COVID fatigue in this regard. People saying we're just tired of being cooped up. We're just tired of being cooped up. We're tired of being careful. We're tired of being scared, right? And our collective fatigue is making some people less careful, making them more careless in terms of their approach to being safe with COVID-19. Another way of looking at it is early during the disaster, if we're talking about stages, people are enthusiastic, right? They approach, this lockdown with the sense that we're going to band together in our community and we're going to get through this, right? That steadfastness to there is hope and there is going to be another side of this eventually. But then we get to this lack of historic spirit, right? Stress is starting to build up. And now we're having people start to say, we're losing our optimism. We'd rather, start to have a negative perspective, right? Angry reactions. And certainly we saw that play out in the US with the protests against the lockdown, not just from a economic standpoint, but from a pure exhaustion standpoint of individuals not willing or wanting to deal more with the pandemic and its repercussions from a lockdown standpoint. And then finally, getting to the point of exhaustion, talking about the talking about the pinnacle of COVID-19 fatigue, people saying, I'd rather just get sick, right, than stay home and be careful. And people stop listening to healthcare leaders, stop listening to the science. And we now are beginning to understand that this phenomena of COVID fatigue can be associated or may in fact be associated with the peaks of what we're seeing in terms of incidence, right? And this is research that is still burgeoning, right, in terms of the impact of this COVID fatigue on the numbers. And we'll pay attention to this and look for more peer-reviewed literature articulating this phenomenon and its impact on the numbers that we're seeing. And why is that important? Obviously, it's important from the perspective of what is the impact to your workforce and what's the impact to your business, right? When we look at then the COVID-19 fatigue impact potential on productivity, one articulation of it is these 5 stages, right? The crisis hits, we have disarray, and stage 2, we have a response stage, right, where we're getting focused. We have that kind of heroic mentality, we're going to make it through. Then we have a regression stage. That's kind of where we're at right now, where people are starting to feel low energy, fatigue, and they're starting to potentially disconnect, particularly with the remote workforce as it stands right now still with most institutions, most organizations. and that disconnect can cause a drop in productivity. Now, we did in fact present data earlier this summer looking at remote workforce and increases in productivity. That was data that was captured during this phase three, that responsive stage. Let's band together, let's get through this, right? We would love, we would love to see an update of that research during this regression stage, and see the impact to productivity now that people are experiencing more COVID-19 fatigue. And then finally, the recovery where people are starting to see the light at the end of the tunnel. They're reemerging with a sense of purpose, if you would. And that speaks to a lot of the cultural impact that a solid approach to combating this COVID-19 fatigue can have on the workforce. And so when we talk about then prevention and having a proactive model, where do we begin, right? And how do we distill it down simplistically so that we can take a practical approach to addressing COVID fatigue amongst our workforce? And so when we talk about our approach and our philosophy, we look at it through the similar lens that we look at preventing workplace exposure to COVID-19 in the first place, right? We want to assess and be proactive in terms of our mental health screening. And so likewise, right, we've recommended taking an approach, a proactive approach to triage those individuals who may be at risk for having a COVID exposure in the first place, right? If you all recall this from last week and previous weeks. And so when we talk about risk stratification, and we talk about identifying those individuals who may be at risk, and then proactively offering interventions, that's what we want to do with our mental health triage. So we'll revisit this. We presented this several weeks ago, and we want to revisit it again today because, again, the fundamentals of this will play out well for helping with identifying your workforce that may be at risk, greatest at risk for COVID fatigue, those individuals who need to have some type of intervention to help get them on through to the other side of this, right? And we'll speak to some of those measures here in more depth here shortly, but we want to basically take an approach that allows us to quickly capture a snapshot of where people are at, right? And then appropriately triage them to the right intervention at the right time. That's our philosophy here at WorkCare. And we're seeing this play out in the news in terms of these type of interventions, mental health interventions, and we're seeing them continue to soar, right? This was just recent, October 23rd, seeing the demand for virtual mental health go through the roof. We presented on this back in March of this year, and we talked about then this trend that we were seeing in the mental health industry, right? Mental health at that time for telemedicine, we're seeing a potential 50% increase, 25 to 50% increase in activity. That was back in March, right? And so we're continuing to see that trend today. Obviously, this is still a lagging indicator on the impact from COVID-19 and an indicator of COVID-19 fatigue, but still yet an important measure that we need to pay attention to because this is also the interventions that we want to have in place to help our workforce, right? There's a myriad of services out there. We're looking to deliver to you a concise methodology, leveraging some leading technological approaches to help with mental health interventions, right? And if we distill it down to, its basics, right? We presented this before in terms of how do you practice self-care? How do you take control of some of the stress that you experience to help combat COVID-19 fatigue? Taking breaks, right? Taking breaks from media, social media, the news, taking deep breaths, practicing mindfulness, eating healthy, exercising. These are all measures that these interventions are going to help individuals through from a self-care standpoint, and when called for, to connect with a mental health provider, as we're preparing to do at WorkCare, so that we can get the appropriate care at the appropriate time, right? And so when we talk about dealing with COVID-19 fatigue, we really have to pay attention to overall mental health and wellness and provide solutions that are going to be nimble enough to reach the masses of people that are being affected by this pandemic from the consequences of prolonged sequestration, if you would, from their coworkers, from their friends, and from their families, particularly as we approach the holidays here. We'll continue to see an increasing rate, most likely, of mental health impact as a result of COVID-19. So with that, we quickly went through our understanding of COVID-19 fatigue, our recommendation on how to deal with it, and the interventions, and we can talk more offline or afterwards and provide you more resources on how to combat COVID fatigue. And I want to leave you with a little teaser for potentially next week's topic, because we want to help innovate your approach to early indicators for COVID-19, wastewater surveillance. Providing wastewater surveillance as a means to get ahead of potential outbreaks in your facilities, right? We know that wastewater analysis has been used in other infectious disease monitoring and surveillance, but we're now identifying ways to leverage wastewater analysis and surveillance to help monitor for COVID-19. Universities anecdotally have leveraged this to identify in dormitories or those students who stay on campus who may be at risk for having an outbreak in that particular facility, and we're able to now hopefully offer solutions that can help you get ahead of an outbreak in your facility without having to directly monitor or do surveillance on your workforce. So more to come. Just a tickler, and we look forward to providing you some information in depth as well as solutions in this regard. So with that, we thank you, and we'll hop to our question period.
Great, thanks, Dr. Harris. I look forward to next week's webinar. That's an interesting topic. You're not going to be surprised by this question. Any feedback on the Pfizer vaccine announcement? Is it on track, early or late, per your predictions?
That's awesome. So yes, the Pfizer announcement, obviously a slight breath of fresh air in terms of a little light at the end of the tunnel, and it is perfectly on track to what we predicted in terms of Pfizer applying for an FDA emergency use authorization this time in November. So as you recall, Pfizer was our front runner that we picked for the vaccine. It's playing out very well in that direction. When Pfizer releases, once they have the EUA, which will happen late this month, late or early next month, our next prediction obviously was when is the vaccine rather going to be available to everyone? And again, that is, to remind you, not predicted until May of next year. That's after the state's pre-order. That's after we see continued phase 3 clinical trials bring us additional data on safety and efficacy. And we're signing up at WorkCare to be a distributor in some states that, to administer the vaccine. And so we will be bringing you more details on the administration thereof as things move forward here.
Yeah, we'll be addressing the vaccine in more depth, so I'm not going to follow up with other questions related to it, but I know that's on everyone's mind. But we do promise we'll delve into that in more detail in the future. There's a couple questions just about the situation in the United States in comparison to other countries. One of them is, were U.S. upticks occurring during holidays like Memorial Day, Independence Day, and Labor Day, and how do they compare to what's occurring right now as we approach the winter season?
Sure. Yes, we did see increases in incidents after those holidays, both anecdotally on the local level as well as across the board. In comparison to what's happening now, we're seeing the increases spike in the same way we predicted in terms of seasonality to coronavirus. If you recall, a month or so ago, we talked about and compared SARS-CoV-2 and its potential seasonality mirroring that of cold and flu season, right? And that being hardest hit potentially in the winter months. That's what we're starting to see play out now, and what we have been seeing throughout the fall. So, and that's again not very different from what we predicted even way back in, I believe, March and April, when we made a comparison to the Spanish flu. That hit in the spring, kind of went quiescent a bit in the summer, and came back with a vengeance, multiple that of what was experienced in the spring. So coronavirus is playing out that way, and that's why we're anticipating things to get worse from even where we're at right now.
Okay, well, here's a question I'm going to interpret a little bit. The question is, why do you think the U.S. is getting worse as we have more mask mandates, more hybrid or distance learning, more work from home employees, et cetera? And I would add, what percentage of case rates do you think are influenced by COVID fatigue and attitudes about compliance?
Sure, one would postulate that COVID fatigue is playing a role in the number of cases that we're seeing now, right? And that's just not Dr. Harris saying that, that's other clinicians and epidemiologists that are doing that analysis. What we also know is that there has been a shift from the community incidence rates and places of exposure. Those exposure risks aren't happening at work for the most part. You as employers have been very diligent in putting in place those preventative measures to help keep your workforce safe, and we applaud you for it. Where we're seeing the uptick in many states, let's say, for example, in Wisconsin, we're seeing the spikes happen in household exposures. And these household exposures are happening because the numbers of people that are having a great time at home in numbers of 25, 50 or more and causing clusters is through the roof. And that data is clearly what we're seeing in the public health numbers that have been tracked in different states. If you look at, in comparison to the Midwest, what we're seeing on the coast, we're not seeing the same level of uptick in New York, in California. And so we want to continue to examine, as we presented that data 2 weeks ago, what is the difference in those differences in those states that were once hard hit and now aren't corresponding with the Midwestern states in terms of uptick. One would then postulate there that sentiment plays a significant role. COVID fatigue plays a significant role. And we'll hopefully get more data on causality, or narrow down at least, as we move forward.
Okay, we have time for one last question. I just want to remind everyone we do answer all the questions and post them on our website. And also want to invite you to submit topics to close out the year. We're going to be continuing these on indefinitely, so we want to make sure we address all the topics that you are curious about or trying to, challenges you may be encountering. So let's jump to the last question. Are there any recent seroprevalence studies showing the percentages of the U.S. population with COVID antibodies, especially in densely populated areas of the United States?
I would so love to say yes to that question. And for those who may have not understood the seropositivity in that question there, it's basically asking how many people are we tracking that have become immune potentially to SARS-CoV-2 as a result of infection. This also gets at natural herd immunity, right? And can we actually reach natural herd immunity from infections, from the population recovering to the tune of 60 to 70% from a COVID-19 infection. Though we have not seen, I have not seen anecdotally any robust data on tracking those who have become or have developed that seropositivity, right? And one can look to the numbers of tests being done for serologic on a serologic basis, and that number is low, right? We learned long ago that serology testing is not as sensitive, is not as specific as the PCR test, is not as useful from a clinical standpoint diagnostically. So we just haven't seen a prevalence of serologic testing to the extent that we've seen with diagnostic testing. That being said, as technology improves, as serologic testing becomes more sensitive, more specific, we may see better tracking of that over time. Now, we can only, what we can kind of draw from what we see amongst the population of infected individuals and conclude is that people are developing immunity. We know that most people do develop immunity after an infection. So as the infectious numbers we track go up, we also are, again, looking to and assuming that those individuals are now out of that susceptible category of population for now. We realize that the opportunity to be reinfected after about 120 days increases. So we'll continue to look at it, but as far as I understand and have seen, I have not seen any robust studies looking at seropositivity as it stands from a global, or not global, but from a macro U.S. standpoint.
Okay, that concludes our session. Thank you all for joining us. Stay safe. We'll see you next week. Thanks, Dr. Harris.
Thank you. Take care and stay safe. God bless.